بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل. آمين يا رب العالمين. My topic today is about mitral stenosis and its radiological science. Mitral stenosis is usually acquired, commonly caused by rheumatic heart disease, and extensive mitral annular calcification in older patients can result in mitral stenosis. Rarely, mitral stenosis is congenital and it accounts about 0.5% of cases. Normally, the mitral valve measures about 4 to 6 centimeters square centimeter. When it is reduced than 2 square centimeter, it is there is left arterial pressure increase and subsequently pulmonary hypertension developed, and the patient presented with symptoms of chronic heart failure and arterial fibrillation. What we see on the chest X-ray on the patient with mitral stenosis, the heart can be normal in size or can be cardiomegaly, mild cardiomegaly, straightening or convexity of the left heart border secondary to enlargement of the left atrial enlargement, double right heart border due to enlarged of left atrium, and normal right atrium shadow. A line from the midpoint of the right border of the double density to the midpoint of the border of the left main bronchus should measure less than 7.5 centimeter in males and 7 centimeter in female. Splaying of the subcarinal angle more than 120 degrees, causing elevation of the left main bronchus and collapse of lower lobe, left atrial enlargement on the lateral view. A normal left atrial should also lie anterior to the line drawn down to the center of the trachea on the dead lateral view, not rotated patient. Mitral annular calcification, pulmonary edema, and signs of pulmonary hypertension. Let us see some examples. Here, this is a normal patient with the normal chest X-ray, and we see here this is the aortic knuckle, and this is the pulmonary artery. And here, this is the region of the left atrial appendage as we see here. Here, this patient with mitral valve disease, as we see here, there is the aortic knuckle, pulmonary artery, little bit prominence, and there is convexity of the left atrial appendage due to enlargement, and here we see the right cardiac border, and here we see the double shadow of the left atrial enlargement. and some accentuation of bronchovascular marking seen bilaterally, especially the lung bases. And we see the blood vessels in the upper lobes is larger than the blood vessels in the lower lobes, and we call this diversion. Here, this is the lateral view, and we see the bulging of the left atrial enlargement here. Here, this is the line, how to see the left atrial enlargement. Here, this is the line from the mid-right border of the double density to the mid border of the left main bronchus, and should be less than 7.5 centimeter in male and 7 centimeter in female. If it is more than this, there is left atrial enlargement. Here we see the carina here, and this is the left main bronchus, and this is the right main bronchus, and if there is a splaying of the subcarinal angle more than 120 degrees, it is left atrial enlargement. Here we see left atrial enlargement. It is posterior to the line from the central of the trachea on the lateral view, dead lateral view. Normally it should be anterior, not posterior. It is here projecting posteriorly, indicating that there is left atrial enlargement. Here this is a patient with a double contour, as we see here, and we see here this is the left main bronchus, and this is the left atrial appendage, and the patient has mitral valve replacement, and we see here this is the left atrial enlargement on the left lateral lateral view. Here, this is another patient with cardiomegaly and with the straightening of the left cardiac border and enlargement of the main pulmonary artery. And we see in this patient multiple fine nodularities involving both lungs. And this confirmed on the CT scan in this patient, and this is due to secondary hemosiderosis due to mitral valve disease, and the patient can present it with hemoptysis. We should not forget the other differential diagnosis of miliary pulmonary nodules. We see the fungal infection, we see pneumoconiosis, sarcoidosis, even metastasis, and others, alveolar microlithiasis, amyloidosis. Here another patient with calcified nodule in patient with mitral valve disease and calcified nodules. Here another patient with mitral valve disease, and we see here the main pulmonary artery is larger than the ascending pulmonary artery at the same level, and this indicates pulmonary hypertension. Thank you very much for listening, and hoping to see you soon in another talk.